Hi, I'm Sherri McAllister. I'm one of the clinical managers with Mercy Home Health. I gave everyone a PowerPoint and we're here to discuss an in-home IV diuretic program. The goal of this program is to meet the triple aim for better care at lower cost and better health. To reduce ER admissions, to reduce readmissions, to enforce medication compliance, improve quality care, and patient satisfaction. This will also help promote disease management, education, and independence by teaching cause and effect to each patient. Why? We're implementing this program to catch early signs of exacerbation and health declines. We want to meet CMS guidelines for decreasing rehospitalizations within 30 days for CHF, which is the nation's #1 killer, and also is one of the #1 hospital readmissions in my area. This will also affect reimbursement. So we want to make sure that the patients are well educated at home so they know how to manage this disease process. We want to prevent CHF hospital readmissions and advance patient care in our home health agency. We recognize that there's a lack of opportunity for outpatient therapy. So there is no available heart failure clinics to administer this intravenous therapy in our area. We have the inability to get to physician's office to have them do the treatment. There's no home health policy that is existing in this area for IV administration. There's no home health competency program, and there's no community pharmacies to dispense the medication, as well as labs who will go out and perform the pre and post timely so that the physicians can have the results so that the nurses can be told whether or not they can implement and start the protocol. The strategic plan of the program starts by addressing the needs of the heart failure patient in the home prior to leaving the hospital. Prior to leaving to the hospital, they have to have an order for home care, they have an order for the diuretic program, they have an order for telehealth, and they're given stat packs before they leave. In the stat packs, there's IV Lasix, there's butterflies to get access, venous access, there's needles, there's syringes to draw it up, there's 40 milliequivalents of potassium, there's conversations about putting Zeroxylin in there. So anything that the nurse would need in the home to give this medication is in the IV stat packs. This protocol can be implemented at any time. The patient has exacerbations in the home, and this is helping us keep them home. The other development of the strategic plan, you need to implement your mission, your vision, your core values, and leadership. You want to make sure compliance and quality is there so that they can help assure that you're meeting your goals. The results that we want out of this program are to reduce hospital readmissions, reduce the number of ER visits, reduce death, reduce decompensation, reduce long-term health costs. We want to improve clinical outcomes, improve patient quality of life, and empower the patients to be able to advocate and take care of themselves and manage their own disease process. So how we want to get this started is we want to make sure that we have a criteria and a pathway, which we started to develop here from the acute care facility to home. Patients with a primary diagnosis of CHF with no acute renal failure can be put on the program. The referring physician needs to be willing to oversee the patient in the community and provide orders. Home health will follow the patient, ensure that the patients have cardiology follow-up appointments, but this is conservative treatment for patients who are not in crisis. If the patients are in crisis, then they need to obviously go to the emergency room for more extreme measures. The emphasis is on patient engagement with intense education regarding self-management. And what we want to do to follow up to ensure that this program is working, we want to have weekly IV Lasix calls. We want to meet with the nurses, have conversations with them, get their feedback. There's a CHF team from the hospital that is on board, which has physicians, it has nurses, it has CHF coordinators, the pharmacy, the lab, and home care. And what we all do is we sit there and we have conversations on how to fix different problems that come up, wrenches that are thrown into the program, expected and unexpected. Right now we have developed a lab slip for the physicians to order from the St. Clair Pharmacy at the hospital. That is our feeder hospital. And this contains the IV-CHF stat pack. If they're unable to get it from that hospital, we also implemented a local pharmacy who will deliver, and the cost is $5 to the patient for each stat pack. And if they get their medications from either one of these pharmacies, it is completely free. We're looking for feedback and engagement from physicians and the CHF coordination team to tell us what they need to help us improve the program and make it work in the home setting to prevent these readmissions. So our overall goal is to work with the hospitals to assure that these patients are not readmitted to the hospital in less than 30 days to make sure that we improve our reimbursement. Thank you.